all of you. This is the second of our national online CME. We plan to have it regularly on the first Thursday of every month from 8 to 9:30 p.m. The main purpose of having these online CMEs is that the experience and expertise of the master teacher reaches even to the remotest clinicians of our country. I feel honored and privileged to inform you that today we are amongst a galaxy of stars of clinical medicine who have very graciously accepted to be a part of today's deliberation. The guests of honor of today's evening are Dr. K.K. Parekh sir, Professor Dr. G.L. Awasthi sir, and Professor Dr. Madhu Chandakar ma'am. Since there is some issue with the network at Dr. K.K. Parekh sir's house, I straight away invite Dr. G.L. Awasthi sir. Sir, it is my honor to welcome you. Sir has been a postgraduate teacher for more than 40 years. He is a former professor and head DMC Ludhiana and the current Director Medical Specialities SPS Hospital Ludhiana. Sir has been a BC Roy awardee and has delivered numerous orations in various prestigious associations. He has actively nurtured IACM since its infancy and has also been a president of IACM. Sir, please bless us with your words of wisdom. Professor Dr. G.L. Awasthi, sir.
भैया से पूछ के जाओ।
अनम्यूट कर लें।
बड़ा करने के लिए कैसे करें?
डॉक्टर एमपी
क्या डॉक्टर अवस्थी सर अनम्यूट कर लें।
खोला था,
इसको दबाइए।
फुल स्क्रीन पे आ गया, अनम्यूट करके सुनाई पड़ेगा।
There is some issue with the network in Professor Dr. G.L. Awasthi's home. In the meanwhile, I'd like to invite our inspirational and dynamic president, Dr. K.K. Parekh sir, who's the heart and soul behind these online CMEs, to bless us with his words of wisdom. Over to you, sir.
Thank you, dear MP. Good evening, friends.
Good evening, sir.
Welcome to the second online CME of Indian Association of Clinical Medicine on hematology. It's my proud privilege and opportunity to extend a warm welcome to all honorable delegates attending today's CME program. I also welcome our legends of IACM and medical fraternity, guest of honor, Dr. G.L. Awasthi and Dr. Madhu Chandakar, both are past presidents of IACM. Thank you very much, Madam and Sir, for attending and sparing your valuable time for this CME program. I also take this opportunity to welcome our learned chairpersons, Dr. Gursaran Sidhu, past president of IACM, Dr. Anil Kulsresht, past president of API Gujarat, Dr. A.K. Tripathi, Dean KGM Lucknow, moderator of today's CME program, and our own honorary secretary, Dr. Kushwa, will be assisting in moderating this CME program. I also welcome and extend my sincere thanks to our galaxy of speakers today, Dr. Naveen Kakkar and Joseph John and Dr. B.L. Bhardwaj, for sparing your valuable time for this CME program on a very common subject which we are coming across every day in our day-to-day practice. We are keeping such very common topics of common interest to the practicing physicians so that they can update their knowledge and get good update from these CME programs. I would like to extend my sincere thanks to Dr. MP Singh, who is the convener and taking lot of efforts, sparing lot of time for this CME program, which he's been doing every month and will continue even in future also. I would also like to extend my sincere thanks to Mr. Ajay Sharma, who is doing all these things. He's behind the curtain, managing all the CME programs on this online CME. So thank you everyone for sparing your valuable time and coming to attend this CME program. I hope that we will be more updated and will be more wise on such a very common topic on hematology, which our speakers will make us update. Thank you very much. Jai IACM, Jai Hind.
Thank you, sir.
Thank you, sir, for your inspirational words as always. Since the issue at Dr. G.S. Avasthi sir's house of the network has still not been resolved, I would now like to invite Dr. Madhu Chandakar ma'am. It's actually my privilege and honor to welcome her. It's a name that needs no introduction anywhere in India. She is the Clinical Director, Department of Oncology at Fearless Hospitals, Calcutta. She has published more than 80 papers in various national and international journals and has been on the editorial board of most of them. She has continued to take a keen interest in IACM since its inception and has also been a president of IACM. I welcome you, ma'am, and would invite you to bless us with your words of wisdom.
Namaste, good evening. All my colleagues of IACM, it's a wonderful experience to be joined by so many colleagues with which we had such good relationship. Today we are here to talk about hematology, thanks to the laudable efforts of Dr. K.K. Parikh and Dr. MP Singh. The topics chosen today are so relevant. We are all facing the problem of interpretation of CBC, and even in the district hospitals and remotest place, all the physicians get such a lot of information from mere interpretation of the CBC. The other two topics, pancytopenia and thrombocytopenia, are so relevant because all of us, whether we are cardiology practitioner, whether we are nephrology practitioner, hematology, oncology, all of us will have experience of thrombocytopenia and pancytopenia in our day-to-day clinical and office practice. So I'm really thankful to IACM for covering these topics today in the CME, and none other than A.K. Tripathi, a good friend of mine, is going to moderate these sessions. And I'm sure at the end of the topics, all of us will be enriched by massive exchange of ideas and information. Thank you, IACM, for this rare and proud opportunity given to me by all the members of IACM organizing committee. Thank you. Namaste.
Thank you,
Dr.
ma'am.
Avasthi
It's
is-
always an inspiration and a matter of a privilege for us to have you amongst us. I would now request Dr. Suresh Kushwaha, sir, Secretary IACM and co-moderator of today's program, to welcome the chairpersons and our moderator, Dean of KGMU, Dr. Tripathi, sir.
Thank you, Dr. MP Singh. It's my privilege to introduce our great teacher, Dr. A.K. Tripathi. Dr. A.K. Tripathi, presently Dean, Faculty of Medicine, Professor and Head of the Department of Clinical Hematology, KG Medical University. His major achievement is former Director, Dr. Ram Manohar Lohia Hospital, Institute of Medical Sciences, Lucknow, past President of Indian Society of Hematology, visiting scientist in technology at National Institute of Health, US, recipient of the National Award from Department of Science and Technology, Government of India, Fellow of National Academy of Medical Sciences, India, Vigyan Gaurav Award, Fellow of Royal College of Engineers, FRCP London, FRCP Glasgow, and so many 130 publication and 5 books edited by him. I invite Dr. A.K. Tripathi as a moderator of this evening. Hello.
Hello. Yeah. Good evening, all of you. It's a rare occasion for me and meeting all of you after a long time. And I'm very happy to see the topics chosen is of great importance for medical practice. And these are very common problem, whether it is pancytopenia or it is thrombocytopenia. And generally, the most important situation where we hematologists get reference from is thrombocytopenia in patients of sepsis, in pregnancy, in various other conditions. So I'm glad to see great speakers here. Definitely, all of us would be benefited by this the deliberation on this very important subject.
Dr. Mem Singh, I'm on. Hello.
Hello. Good evening, sir.
Good evening, Dr.
Good evening, sir.
Dr. Tripathi, please.
Pushpa sir, the issue at Dr. Professor Avasthi sir's about the network has been resolved. I would take this opportunity to welcome Professor Avasthi sir, who's the guest of honor for today's CME. He has been a postgraduate teacher for more than 40 years. He's former professor and head Department of Medicine at DMC Ludhiana and the current Director Medical Services at SPS Hospitals. Sir has been a BC Roy awardee and has delivered numerous orations in various prestigious associations. He has actively nurtured IACM in its infancy and has been the president of IACM. Sir, it is our honor to have you with us. Please, sir, bless us with your words of wisdom.
Thank you very much, Dr. MP Singh. I'm so glad to be a part of this CME. I am happy to see Dr. Parekh, Dr. Madhuchanda, Dr. Singh, and all my senior colleagues I haven't seen them for a long time. It is a very good occasion, and the subject done by you, Dr. MP Singh, and is very important. Leaving aside everything, I think CBC is not ordinary investigation. If you look at NLR, PLR, the way we are looking at them from different diseases in rheumatoid arthritis, cardiovascular, or diabetes, then it is a renewed interest and everything is really very important and no more a routine one. The other thing is that all the speakers seem very learned. My senior colleagues, I have known them for long and they will do justice to this. To look at this convening of CME on WhatsApp, it looks simple, but actually it is quite difficult, and I must congratulate and give you my regards for. I'm very happy to be guest of honor. Thank you very much for the honor given to me. I'm all my friends and delegates. Thank you.
Sir, it's an honor for us that you graciously accepted to be a part of today's deliberation. I would now request Dr. Kushwa sir to introduce and welcome the other chairpersons who have been stalwarts of IACM since its beginning.
Thank you, Dr. MP Singh. Madam Sidhu.
Can we request Mr. Madhukar Saraswat to unmute?
Dr. Madhu, please unmute.
Saraswat to unmute.
And
अनिका वो कह रहे हैं कि मधुकर सारस्वत को अनम्यूट.
Good. Unmute हो गए डॉक्टर कुशवा.
Kushwa sir,
म्यूट हो गए आप,
अच्छा,
अनम्यूट हो.
I invite Dr. G.S. Sidhu. She is
आप हो गए
Chief of Department of Medicine, Sidhu Hospital, Doraha.
नहीं
She
है,
is
इसको बड़ा कर दे.
she is the National President of IACM 2012 and Chairperson of the Epicon 2014 at Ludhiana and Principal Investigator in many trials. I welcome Madam Sidhu as a Chairperson in today's web CME.
Thank you, Dr. Kushwaha. And I am so happy to be here because we all feel, IACM is our family. And today's CME, the credit goes to Dr. MP Singh, Dr. K.K. Parekh, the stalwarts. And it is so nice. We're so excited. IACM we are so bonded as with our family. And such a beautiful topics what we are going to talk, so relevant with our clinical practices. And I welcome Dr. Naveen Kakkar to give this first talk on this CME today, and which is so very important, that how to interpret CBC. It's the knowledge about how to interpret CBC is a dream come true for every physician, because that's the first report we all see, and how to interpret that is so much so important. Dr. Naveen Kakkar is MD Pathology from CMC Ludhiana. And right now he's professor in Department of Pathology on Medical College Hospital, Kumarhati, Solan. Dr. Naveen, I happened to see the Solan Medical College. This was, we went to see Dr. Sanjeev Uppal there. And he's got keen interest in hematology analysis, coagulation testing, and hemoglobin disorders and hemolytic anemias. So I welcome Dr. Naveen to give a talk on how to interpret.
Okay. Thank you, ma'am, for the kind introduction. And I'm happy to be, I'm the only pathologist probably in this gathering of physicians and doyens of.
That's more important. We need your inputs. Without you, without pathology, the physicians can't do anything.
Right. So I'll just share my screen.
Yes,
so
please carry on.
Yeah, so if you can confirm if my screen is visible to all.
Yes, it is visible. You can make it full screen also.
Yeah,
yes,
done that.
Yes, good.
Right. So I'm going to start.
I request everybody else to please mute your computers or your cell phones so that we can listen to the speaker.
Okay, so here we go. I met Dr. Kushwaha at a conference in Patiala, and he booked me there. So, in fact, less than a month ago, in fact, 5th of March. So yeah. let's begin with the background. Why should you, as physicians, know basic CBC interpretation? It's not a great question. You should know a bit about manual and automated techniques. Some tips towards interpreting CBCs before I go on to the case studies. And I'll run through case studies more than just the theoretical discussion, but a background is important. Now, I feel a CBC is what they don't teach us in medical school. We are taught RBCs, WBCs, platelets kind of with diseases in isolation, but never to put 2 and 2 together and get a diagnosis, usually. You see these reports often, the 3-part analyzer report, more complex 5-part reports, and there are actually lots of numbers that we have to make sense of in everyday life. And your job as physicians, when you take a history examination and routine some investigation, and our job in the lab is connecting the dots to make this diagnosis, a rabbit, so to say. So let's see the CBC with a different eye, something beyond numbers, using the numbers only. So if you've not seen Drishyam 2, I would recommend please see that. It's a very good movie. And 2 of the statements or one dialogue there that Ajay Devgan says, I thought was appropriate for this talk. सवाल ये नहीं है कि आपकी आंखों के सामने क्या है, सवाल ये है कि आप देख क्या रहे हो. So all of us see these numbers every day, lots of numbers, but what do we make of it is what the interpretation of a CBC takes us there. So why should you know about a CBC? It's the commonest test all physicians order all day. You have lots of advancements, and from the basic 8 to 18, and even some analyzers give 56 or even more parameters. Most of us tend to use the routine good old 4 to 8 parameters. And remember, not all the reports that you may see may be validated by a trained hematologist. So you will be required to make a decision on your own, like you do on X-rays and EKG. You hardly depend on the cardiologist or X-rays for common things. If you understand the CBC well, your clinical decision making is faster, and you can order relevant test earlier and get to your diagnosis fast. So a bit about the manual and automated methods. We know that the manual method earlier was slow, took time, was imprecise. Now, this is not a printer. This is actually an automatic dosa maker. So what is coming out is a dosa, thin paper dosa, and you will fill in the stuffing and serve. So luckily for us in the lab, Wallace Coulter gave us the cell counters way back in 1953. So that's the Coulter principle. Basically, a cell passes along the electrodes, a positive and a negative electrode, and as it passes, it cuts the current. So with the number of cells, when the current is interrupted, the machine can count how many cells pass. It gives you the number. With the size of the cell, it gives you the volume. So that is how an instrument calculates what is an RBC, what is a platelet, what are the WBCs. So you may have given this query to your laboratory colleagues. Can you repeat this hemoglobin doesn't look like whatever you're saying? And he runs it again in the machine and gives you again, okay, 7.3 again or 7.6, not very different. So what the laboratory person is actually checking is the precision of the machine. All machines these days are highly precise. They are computers. You give them the same sample again and again, they'll give you the same, nearly the same value. But it is the laboratory's job and the technicians and to make it accurate also, using quality control and other measures. So the machines have evolved over the years from very basic ones to 3-part to standalone automatic 5-part, where you can load in 100 samples and walk away and they give you the analyzer reports. The best chip, even in these times with the latest advancements, is still between our ears. So we need to interpret the CBC in our mind while getting the accurate values from the instrument. So the real truth now is automatic CBCs are easily available. Hardly any lab does not have a small 3-part analyzer. Very few tests are done manually. So you get, like I said, a lot of valuable information which is underutilized, as I feel. We use mainly numerical data, and there is suboptimal qualitative interpretation. We use the numbers well, but we don't connect them well. And graphical data is hardly ever used. I'm not focusing today on anything on graphical data, but maybe on another day we'll look at how these graphs that are generated help us in actually reaching a diagnosis in a snap. So some tips on background of looking at the CBC. So some laboratory truths, which is one, hematology analysis is very precise. So you feed a sample with a hemoglobin of 12, feed it 10 times, you'll get similar values, 12, 12.1, 12.2. So there's no problem with the analyzers that way. Errors, if you're seeing in the report, 75%, believe it or not, are in the pre-analytical phase, before the sample reaches the lab. So sample taken from a line has a partial clot, or a slow draw, or anticoagulant not enough, or sample not enough. These are the problems that the laboratory face. So the physicians must know adequate sampling is a prerequisite to an adequate or an accurate report. So 5-part, if you have a big instrument which gives you a 5-part differential, which means neutrophil, lymphocyte, basophil, eosinophil, and monocyte split well, is actually fairly accurate and at times better than the manual counts. Machines have evolved so much. And not to forget the blood smear, because I'm talking about the CBC. A blood smear is a part of that on selected situations. It can give you schistocytes, basophilic stippling, malarial parasites, sickle cells, blister cells, and G6PD deficiency. There's a whole lot of gamut of diagnosis that a blood smear only can give you. No cell counter can replace the human mind or the eye. And like you, we are also desperate for clinical information in the lab to make sense of the values before we release a report. So to look at the CBC, the approach would be look at red cell parameters, WBCs, and platelets. Sizing of red cell, very important. Are they small, normal, or large? Are there any abnormal cells on microscopy? And we'll leave it for another day, the peripheral smear. Look at the reticulocyte count. That will tell you a marrow response to anemia, and bone marrow and other ancillary tests, depending on whatever you're suspecting clinically and what the CBC tells you. So basic background approach to anemia. You have a patient with anemia. Your first question is which type, and you look at the RBC indices to decide that. So remember, your hemoglobin might be 7.5. Your next question should be, what are the RBC indices telling me? And these are the indices, the MCV, MCH, and MCHC. A bit about these indices. MCV is the volume of one cell. So the mean, when we say mean, it's a mean volume of all red cells taken together, hemoglobin concentration given by MCHC, and hemoglobin of all red cells other than one is given by MCHC there. The normal MCV to take home for your mind for healthy adults is 80 to 100. Keep that figure in mind, very easy to remember. And maybe you can remember this one also. MCHC, select indications only. So looking at the practical usefulness in daily practice of indices for you and even us in the labs, MCV takes the cake. Most important one, MCH, yes. And if you can't read the third one, that's fine. That's MCHC, and that's our joker. It'll come in handy one day, but not in daily practice. So we like your McDonald's fries, your red cells can also be small, medium, or large. So on normal MCV, 80 to 100, we are dealing with normocytic red cells. Low MCV, microcytic, and higher MCV more than 100 is macrocytic red cells. So are we missing something here? So let's not be mean. Remember when we talked about these volumes, we said mean, mean, mean. So mean can hide some things for us, and that is why we need to look at another parameter. I'll give you an example to illustrate this. Let's say your patient's normal MCV today is 92. He develops iron deficiency over a period of time. MCV has now fallen to 82, which means the cells are becoming microcytic, becoming smaller and smaller. But let's say he comes to you now on the day that his MCV is 82, and you order a CBC and you find it in the normal range. 80 to 100 was normal. He's got 82. You say it's a normocytic normochromic picture. So what we are missing is a parameter called red cell distribution width. All analyzers give this by default along with the red cell indices. It's a must-have, must-interpret parameter, and this fits in your final cog or the final puzzle for your anemia diagnosis. I'll give you some examples. So basically what this means in simple terms is if your red cell population is uniform, it may be large or small. So these are normal cells, your REW is normal. Red cell distribution width, it basically tells you as a measure, are your red cells differing in volumes and sizes? If they are not, REW will be normal. 11 to 15 is normal. If the RBCs are of varying sizes and shapes, your REW will increase. So with that background, anemia diagnosis has become better. So I'll come back to our same patient. Let's say a normal MCV drops to because of iron deficiency to 82. It now comes to with a normal MCV. Still in the normal MCV, although he's dropped from his normal value. If you look at the REW is 17.4 here. Normal was this. So although the MCV says it's a normocytic anemia, REW tells you no, there is a variation in the cell population. So without seeing the smear, you can assume that because it's on the lower side, the MCV, there must be microcytes along. So lots of these indices, we can actually predict what we are going to see in the blood smears. So it's a famous movie and the famous picture. So this is your red cell indices. Please do not interpret without circuit, which is our RDW. If you have anemia, you have only 3 ways to go. So if you have microcytic anemia, then only about 5 differentials, of which 3 are more common. If it is macrocytic, maybe 8 to 12. If it is normocytic anemia, then you may deal with 200 disorders. It may be diabetes, tuberculosis, any disorder which may present with this anemia. So this may not be a disease per se, but it's a normocytic anemia is a sign of another disease underlying. So let's look at microcytic hypochromic anemia first. So when you have microcytosis, the cells are usually hypochromic, especially in the late stage. You have limited causes, these 5 only that you deal with: iron deficiency, thalassemia, anemia of chronic disorder, sideroblastic anemia, and lead poisoning. Lead poisoning becoming less and less common. Sideroblastic requires a marrow for diagnosis. You may suspect it on the smear. This is what we deal with more often. Remember, we are in the thalassemia belt, right in the middle of the thalassemia belt. So green is all thalassemia. We have some other hemoglobin disorders also. So a thing to remember, although we say iron deficiency is very common in India, yes, but few microcytic hypochromic anemias, some of them could be thal carriers, thalassemia trait. So how to differentiate between iron deficiency anemia and beta thal trait? Hemoglobin low, beta thal low or normal. I'll illustrate with a case. RBC count is low. RBC count is relatively higher in beta thal trait for the same degree of hemoglobin. What do I mean? So let's say your iron deficiency patient has a hemoglobin of 10. Beta thal trait also hemoglobin of 10. The IDA patient's RBC count may be 3.5 million, while this patient may have 5.5, out of proportion to your hemoglobin. MCVs are low in both cases, so is the MCH. REW is an important parameter here, a very important one. REW is high in iron deficiency anemia, although it is and normal in or slightly high only in beta thalassemia trait. Another thing that you can do is divide your MCV by your RBC count and you'll get a value. If that is less than 13, you're probably dealing with a beta thal carrier. If it is more than 13, most likely iron deficiency. So a very important differentiating point here is the red cell distribution width. It's a must-look parameter in all anemias. And remember, we are in India, so we will have a lot of patients with iron deficiency who also have beta thalassemia trait, in which case you might need more confirmatory tests, but your indices still might give you a clue, although a bit diluted. So let's say we said earlier, few microcytic anemias could be thal carriers. Now, what about this case? Hemoglobin is 14. Hemoglobin is 14. There is no anemia at all. However, MCV is so low, RBC count is disproportionately high. With 14.2, I would expect 5 or 5.5 million. This is almost 1 million more than that. MCH is low. MCHC we don't need to look at. RDW is normal. So gross microcytic hypochromic anemia, not even anemia, gross microcytic picture with a normal REW. And this is the classical picture of a beta thal trait, most like in an adult male. Because in females, your hemoglobins are lesser, and they might be having borderline or mild anemia also. So in adult males, if you find this picture, this is 99.9%.
Dr. Kakkar, please, video.
You can't see the video?
We can see the video.
We can see the video. The video is clear, sir.
It's perfectly clear.
Yeah, so there must be a problem at your end. Please have a look.
Yeah. Yeah, we are good. We can see everything.
Okay. So shall I continue?
Yes, you should continue.
Okay. So just a misconception sometimes that thal carriers are anemic all the time. No, adult males may not be anemic at all. So a thing to look at, and gross microcytosis, normal REW, think of thal trait. And you can order an HPLC to confirm your diagnosis. Now, what about the reticulocyte count and left shift? Now, these are the cells that we deal with in normal daily life in our reports or the peripheral smears. And this is where they come from, the marrow. So whenever you require more RBCs or require more neutrophils in infections, you can get a bit of immature cells leaking out into your circulation. So if a patient has sepsis, high TLC, you may have band metamyelocytes or myelocytes circulating in your blood, even an odd blast. That's not a rarity. And if you have severe anemia, especially in hemolytic crisis, you may have polychromatic RBCs, which are reticulocytes or immature cells or even nucleated red cells. This is a picture of normal reticulocytes as we see on the smear. This is a patient with hemolysis. You can see the degree of reticulocytosis. This is about 40% of all cells are reticulocytes. This means gross hemolysis. You can even get this when a patient is anemic and given hematinics. The marrow suddenly starts producing and throws up reticulocytes. So reticulocyte is normally 0.5 to 2.5% in adults. It's a measure of erythropoiesis. Please ask your pathologist or lab for the corrected retic count. And you can calculate on your own also. One example, simple formula, patient's hemoglobin divided by expected hemoglobin multiplied by the patient's reticulocyte count. So if the patient's hemoglobin is 7.5, expected is always fed as 15, multiply by the 4 retic reported, and you get the corrected count. If your corrected count is less than the normal count, that means your marrow is not responding. If your corrected count is good, that means the marrow's erythropoietic response or in response to the anemia is good. Another example, reticulocyte count is 12, hemoglobin is 6.5, your corrected retic is 5.1. So this means the marrow has acceleration of turnover. It's functioning well. So what about the blood smear? I said this earlier. Some of these things like basophilic stippling, sickle cells, spherocytes, many of these are diagnostic cells, can be seen only in a blood smear, may be indicated often by analyzers depending on their model and companies, but I want to rely on my eyes for these cells. And you must use the smear request judiciously. So let's say, suppose you run a private nursing home and you have, say, 75 CBCs a day. If you ask for a smear on all of them without a proper indication routinely, then your pathologist's eye will get fatigued by the normal cells. So you choose your smear request judiciously in patients with organomegaly or MCV is altered. If you keep on repeating on normal counts, then your pathologists will start focusing less on abnormal cells also. So choose your smear request judiciously, maybe automated counts for routine samples, or the first, and do a smear when the patient is first admitted, always recommended. So I'll just take you through case studies now, using these as examples to illustrate what we are looking at in terms of interpreting CBCs. So I'll split them into RBCs, WBCs, and platelets, and we'll go that way. So the first case is, this is not the first case, just an example to illustrate how to approach these values. So this is a male with hemorrhoids. So this is your red cell block. So in the red cell block, please look at hemoglobin, RBC count, and hematocrit. The next block is indices, and finally combined with REW. If you look at this in blocks, it will give you good information, diagnostic information at times. Then move to your WBC block, your TLC, the differential count, and finally the platelets. After you've done all three, put them together. So are all 3 cell lines low, are 2 cell lines low, etc. Then combine with the diagnosis, your clinical impression. And then probably you'll be closer to a diagnosis based on your CBC. So I'll illustrate this through some case studies now. So case study 1, this is a 17-year-old girl with menorrhagia. So let's start again. Is the patient anemic? Yes, 7.6. Obviously, RBC count and hematocrit are low. What is the kind of anemia? MCV is low. Normal was 80 to 100, so it's a microcytic anemia. MCH is also low. So my diagnosis here is a microcytic hypochromic anemia with a hemoglobin of 7.6. Next, look at your REW. REW is high. TLC is normal. DLC is normal. Platelets are on the higher side, which you would expect if patients have blood loss. So blood loss also triggers a bit of accelerated thrombopoiesis. So this goes with the blood loss history and microcytic hypochromic anemia with a high REW. This is iron deficiency for 95% sure. So you get your iron studies done, ferritin will be low, serum iron will be low, transferrin saturation low, TIBC will be high. So classical iron deficiency based on these indices. I'll just show you one snippet of the smear. So that's a normal smear on the left side, and this is iron deficiency, small red cells, more empty looking, lots of variation in shape and size. That is the reason REW was high. Case 2, this is a 30-year-old lady for elective cholecystectomy, maybe 2 days from now. Again, is the patient anemic? Yes. RBC count is disproportionately high for this amount of hemoglobin. I would expect maybe 3.54 million max, but this is 5.1 million. So your eyes are alerted to something. MCV is low, MCH is low. So again, we are dealing with a microcytic hypochromic anemia with unusually high RBC count. But look at the REW. REW is completely normal, which means there is not much variation in the size of the red cells. Sorry, between the red cells. The size is smaller than normal, but in that population, there is uniformity. TLC is normal, platelets are normal. So again, dealing with a microcytic hypochromic anemia, but now with a normal REW. So this is a classical picture of indices suggesting of beta thal trait. Now, if you were to calculate the Menzer index, which is, let's say, 61 here roughly, divided by this, you'll get that less than 13. So that's indicative of beta thalassemia carrier. You should advise an HPLC in this case. And this in your history, you may have some of these patients roaming around with a microcytic hypochromic anemia not responding to iron therapy that many of physicians might get looking at the picture. However, the REW tells you this is not iron deficiency, this is beta thal trait. They will not respond to iron therapy. So that's how the smear looks like. Normal on this side, on the right side, lots of target cells, small cells. But if you note, the population is uniform. They're smaller than the normal cells, but very uniform. That's why the REW is not raised. Another case, 35-year-old lady with pallor. So again, let's approach it the same way. Is there anemia? Yes. RBC count, hematocrit is low. What is the kind of anemia? Now we are dealing with a macrocytosis. MCV is more than 100, 120 in fact. MCH, not much of role here. They'll just support the MCV. REW is increased, which means there must be a lot of poikilocytosis, different shapes and sizes of these large red cells. Let's look at the TLC. That's low. DLC seems normal. Platelets are low again. So you're dealing actually with a pancytopenia with a very high MCV with a high REW. So that's again a picture, a profile where you can, as hematologist, even before the smear comes, I can think this is most likely a megaloblastic anemia. where your MCV is raised, and late, we know that late megaloblastic anemia, you can have all cell lines involved. So I need to look at hemoglobin, quickly jump to your MCV, look at your RW, decide the kind of anemia, correlate with the rest, and you have your diagnosis. So pancytopenia in the late stage of megaloblastic anemia. That's how the smear looks like. So you see the less number of red cells because of the marrow destruction that is happening of the precursors. So hypersegmented neutrophil, macrocytes, macrovalocytes, classical megaloblastic picture. Now this variation in shape and size gives rise to the high RAW that you saw. Another case, 55-year-old male with history of alcohol abuse. Is there anemia? No. So obviously your red cell parameters are fine, but your MCV is raised, 112. REW is normal, which means the cells are large, but they are still uniform. They are not very different from each other in that population. Sorry. TLC is normal, platelets are normal. So we are not even dealing with an anemia here. Alcohol abuse here is giving rise to what is called a non-megaloblastic macrocytosis. So some of these patients and liver disease and other disorders may cause this, thyroid or renal disorders, but the commonest one, at least in Punjab, is, and in many other states, would be alcohol consumption. So a high MCV alone, they may be anemic. If they are anemic, but the RW is normal, you're still dealing with a non-megaloblastic macrocytosis. That's what the cells look like. In fact, you can argue these cells look fairly close to normal cells. Yes, they do, because they are so uniform, you can't even make out the difference in sizes. So that's a non-megaloblastic macrocytosis, not even causing anemia. Now we said the MCHC could be the joker. So let's come to where the joker may help us in at least one diagnosis in life. This is a male with recurrent jaundice in childhood and with anemia and a tipped spleen. So as a clinician, you would probably think this is some sort of hemolysis. Yes. So let's proceed. Is there anemia? Yes, of course. So RBC hematocrit go along with that. What is the type of anemia? Seems normocytic. REW is slightly raised, not much. Reticulocytes is 25. So you're definitely dealing with a hemolytic anemia since childhood. And it doesn't seem to be THAL because it's not microcytic. Now that is where TLC is normal, platelets are normal. This is where our joker comes in. And the joker is that parameter that we said is hardly ever used. But in this disorder, it may be diagnostic. 37.2, normal is 31 to 35. A raised MCHC is fairly indicative of the presence of spherocytes in the smear. So this patient had hereditary spherocytosis. A caveat, not all patients with spherocytosis may show a high MCHC. It depends on the number of spherocytes. So patients with spherocytosis may have anywhere between 3 to 7% spherocytes in the smear, to 20% to 40% to 70%. The more the number of spherocytes, the MCHC is going to be affected. So with 3 to 5% spherocytes, MCHC may be normal. But if you find this raised, it's a parameter which is not raised beyond normal in many conditions. If you find this raised in this setting, without seeing the smear, you can think probably spherocytosis. Obviously, you need to confirm with the smear and osmotic fragility testing. So that's a normal smear, and these are your dark, small spherocytes lacking the central pallor, and these are the ones that give rise to the high MCHC. So remember this joker in the pack for this disease. Another case, this is a 60-year-old male with pallor and lymphadenopathy. Is there anemia? Yes. Now, if you see these other parameters, they seem to be in a mess. So I'll just talk about what is called the rule of 3 in hematology to look at. The rule of 3 that most of the clinicians are aware of is hemoglobin multiplied by 3 is roughly your hematocrit. So 5.6, maybe round it off to 6. So my hematocrit in this patient should have been about 17 or 18%, while it is 6.9%, not matching at all. The second part of the rule of 3 is your RBC count multiplied by 3 should roughly be your hemoglobin. Even that is not being followed. MCV 130, I can believe, but these two parameters are totally unbelievable. RW is never low. It's always normal or raised. So what I'm dealing with is a complete mess of parameters, and you wonder in the lab what has happened. So in this error, this error that we think the machine has made lies a diagnosis. So if you look at TLC is normal, platelets are normal. Your red cell parameters are in a mess, and the diagnosis here is possibly cold agglutinin or an autoimmune hemolytic anemia, maybe even one type. Now, why is that? Because let's take you to the next picture. So in this patient, there is autoagglutination of red cells. So these clusters of red cells pass off as one. Imagine 5 or 6 red cells counted as one in the machine because they are passing together. So the machine underestimates the red cell count, and all indices are derived from this combination. So all indices are wrong, and your REW doesn't follow the rules. But this wrong indication or the wrong indices in the lab to us means most likely autoagglutination. We would actually keep the sample at 37 degree for about 20 minutes, run it again, your value will come back to normal. So in this case, if I see this, I will call up the clinician and advise a DCT ICT stat to get your diagnosis. So the instrument is actually giving you the diagnosis looking at these values. Another case, 25-year-old male with fever and epistaxis. So you have look at some, you think there's a problem with the white cell and the platelets probably. Again, let's start this way. Is there anemia? Yes. What's the kind? A bit on the macrocytic side, but still within normal range. The rest is fine. REW is also not much raised. TLC is low, platelets are low. So you're dealing with the pancytopenia, and you want to now see, is the marrow producing enough, or there is a problem with the marrow? The reticulocyte count, which is corrected, is 0.01%, very, very low. So this is an indicator of suppressed erythropoiesis. So your probable diagnosis here would be aplastic anemia. You would advise a marrow quickly. So dealing with pancytopenia, you can have 20 other causes, sepsis, acute hemolysis, sometimes, depending on if the spleen is big, hypersplenism. While in this case, if the spleen is not there, these are the parameters, and your retic is low, go for a marrow straight. So possibly aplastic anemia. So normal count here, and here your platelets are low, WBCs are low, and anemia is there. So nothing drastic in the smear, just that the cell counts are low. So, okay, another lady, 45 years old lady, fatigue for 1 month. Let's look at it again. Hemoglobin is low, so there is anemia. What kind? We think normocytic. TLC is normal, platelets normal. So my impression right now would be a normocytic normochromic anemia. However, we've forgotten circuit, our important red cell distribution width, which is 23.7. So what is happening here? If the MCV is normal, why is the REW raised? Because there must be cells both sides on the macrocytic and the microcytic, so that they cancel out their volumes and the mean is normal. I illustrate that in the. So this is a dimorphic anemia. Again, your MCV being normal, you are able to say this is dimorphic based on your REW alone. So what happens here? It's a tug of war for the MCV. Your macrocytes, yeah. So your macrocytes pull it this side, your microcytes pull it this side. Your mean comes back to normal. However, the red cell distribution width notices that there are large size and small size, and that is raised. So that's the whole point of looking at the REW in a different light. So that's a smear of a normal patient, and this is what this smear showed. So you have the large cells and you have the small cells, these empty-looking cells. So the net effect is your MCV is normal. So do not be fooled by the red cell indices alone. Use the red cell distribution width alongside to interpret. So let's go to WBC case studies, 1 or 2. So 35-year-old male with sepsis. Is there anemia? Yes. Normocytic, REW is slightly raised, so there must be variation, but that's not a prime concern. TLC is 55,000. When if you tell somebody TLC is 50,000, your first impression might be, is it a leukemia? And in this case, there is some left shift, neutrophilia. So it's a neutrophil lymphocytosis, leukocytosis with a very high TLC. Platelets are high, as you would expect in any infection, although late sepsis platelets may fall. So this is the typical leukemia reaction in the background of infection. Is there a doubt of CML? Maybe there at times, as if the left shift is more. Then you need to look at the clinical profile and molecular testing if required. Usually not indicated, you know you're dealing with bad sepsis and this can go wrong. However, sometimes your counts may be 80, 90,000, in which case you may want to distinguish from CML. So that's this picture, bad sepsis, neutrophilia maintained. Okay, another 55-year-old male, fever with gum bleeds. Is there anemia? Yes, mild anemia, normocytic, REW is normal. So mild normocytic normochromic anemia. TLC is like our case, the last case with sepsis. However, the differential, the pathologist has reported blast for you. So there is nothing, no other, and with thrombocytopenia, no other diagnosis but an acute leukemia. And then you have to worry about is it myeloid or lymphoid based on cytochemistry or immunophenotyping and go for further management. That's acute leukemia. And this is a smear. You see these blasts, large MSO cells. And if you see an OR rod, if the pathology sees an OR rod, then we can commit this is AML. If we don't see, then it could be AML or ALL still. You would need immunophenotyping to confirm. 65 years old male with fatigue and lymph node enlargement, mild anemia, normocytic normochromic type, TLC is 68,000. So you're dealing with a gross leukocytosis. The differential count shows you a lymphocytosis of 85%, platelets is 2.2 lakhs. So we know the pathology lies here. 85% lymphocytes of this percentage would be 50,000 plus. So it's an absolute lymphocytosis with lymph node enlargement, elderly male. You are dealing with chronic lymphocytic leukemia. And remember, this also needs a flow cytometry diagnosis in these times before you start treating. So that's your normal smear. And you see lots of these lymphocytes and smudge cells in the smear. Okay, another case, 65 years old male with fatigue for 3 months, mild anemia again, normocytic type, so nothing much to worry. This side, TLC is 1,60,000. So remember, TLC is a 1 lakh, 2 lakh, 3 lakh, 4 lakh. So these kind, you're probably dealing with a CML, chronic myeloid leukemia. And the differential here is very, very suggestive. You have all kinds of myeloid precursors, great degree of left shift, even up to blast stage, eosinophilia, basophilia, platelets may be normal or raised. So this is a classical CBC profile of a patient with CML. Now remember, this differential is done by a human eye. Your machines might give you only neutrophils and lymphocytes. So in which case you may find 89% neutrophils, 10 lymphocytes, and 2 monocytes, a differential like that. However, in a TLC like this, you're probably dealing with a CML. And obviously a smear will be done to give you this differential. So it's
Dr. Naveen, can we wind up?
Okay, just 2 more slides. Yeah.
Right.
Okay, so this is a Ugandan student from Uganda. Hemoglobin 13.5, TLC is, there is leukopenia, neutrophils are normal, lymphocytes are normal, pictures normal. Now, I brought this up because we actually had some students from Uganda having a CBC at our hospital when I was in CMC, and we faced this problem. And we have lots of students in lovely professional university in Jalandhar, Chandigarh, and other universities from abroad. So what we did, they were tested for HBS, HIV, everything was normal. And this is actually a normal TLC for this ethnicity. So we didn't know it till that time, then we realized. So there are papers clearly saying there is genetic neutropenia in people of African origin, also called benign ethnic neutropenia. So many of them may have a neutrophil count which is normally low. And we should not worry about chemotherapy thresholds or treating them or investigating further. Okay, for platelets, I'll maybe take one case study only and then I'll wind up. This is a lady with petechiae for 3 days, no organomegaly. Only platelets are low, everything else is normal. So isolated platelet count low, no organomegaly, otherwise hale and hearty, you're dealing with probably ITP. I'll take one more because important for the clinical sake. Okay. This is a 55-year-old lady. A pre-op CBC was done. She has no history of bleeding at all. Hemoglobin was 11.2, TLC 7,000, and platelets 7,000. So you would expect some, maybe petechiae, some epistaxis, but there was nothing. What did the smear show? The blood smear showed large platelet clumps. They were there in the tail also. What did we do in the lab? We took a repeat sample in citrate and heparin vials. And in the platelet count in citrate was 1,85,000, heparin was 2,10,000. So we gave the final count as 2,10,000. So because of the clumping, the instrument failed to count these platelets, but the human eye picked them up and we had to sort it out this way. This condition is called EDTA-induced pseudothrombocytopenia. Pseudo because it is happening only when the sample is taken in EDTA in some patients. So on these cases, ask your lab to do a citrate or heparin sampling if the clumps are too much. Usually the lab will initiate this on their own. And leave the rest. And just one last thing. So the lab and the clinician should never fight. Please talk and solve your issues for our patient who's waiting for an accurate report. Thank you so much.
Thank you, Dr. Gakkar, for a very elaborate and a very nice presentation of the CBC. I think you answered most of the questions. In case we have any queries, we can take it by the end because I think we are running short of time.
Sure, ma'am. No problem.
So, thank you very much. And over to Dr. Kushwaha.
Thank you, ma'am. Next chairperson is Dr. Anil Kulsist from Ahmedabad. He is a senior physician of Ahmedabad, past president of Gujarat API. Now I request Dr. Kulses to introduce next speaker. Dr. Kulses, please unmute yourself.
Am I audible?
Yeah, audible.
Yes.
Yes, sir, you are audible.
Good evening, sir. Thanks to Dr. K.K. Parekh and Dr. Suresh Kushwaha for giving me this opportunity. It's a great clinical session talking about hematology. It's really day-to-day practice. It helps a lot. So after covering CBC, now we are moving on to a case of thrombocytopenia. And to talk about a case of thrombocytopenia, I feel privileged to introduce Dr. Joseph John. Dr. Joseph John is a clinical hematologist. He is a clinical hemato-oncologist and bone marrow transplant physician. He is at present professor and head of CMC Ludhiana. He has done his MBBS and MD from CMC Ludhiana. Then he did his DM from CMC Vellore. And his main interest is in hemophilia-like diseases. And he has a student DM clinical hematology under him. So I will request Dr. Joseph John to talk about approach to a case of thrombocytopenia. Dr. Joseph John, please. Good evening, sir. Please go ahead with your presentation. Unmute yourself, sir. Sir, unmute yourself. Sir. Dr. John, please, sir, unmute yourself. Hello.
There seems to be some issue with his connectivity at the moment. Let's go on to the next lecture and then we'll come back to his lecture. Dr. Kushwaha, please introduce the next chairperson and the lecture.
Hello. Good evening. Next speaker is Dr. B.L. Bharadwaj. He is senior vice president of IACM presently and past principal of the Government Medical College, Patiala. He will speak on the pancytopenia. Hello, Dr. Bharadwaj.
Yeah, we can see the slides. Go ahead, Bharadwaj.
Dr. Bharadwaj. डॉक्टर एमपी डॉक्टर भारद्वाज को कहें देखें टेलीफोन करें
I'll just call him, sir, and let him know. By the time Dr. Bharadwaj is available for his presentation, may I request Professor Dr. Tripathi to moderate this lecture, which was just given by Dr. Kakkar sir.
I must, yeah, am I audible, Dr. Singh?
Yes, sir. Yes, sir.
I must congratulate Dr. Naveen Kakkar for a very, very illustrative and interesting presentation. And he has given a very good examples of particularly non-megaloblastic macrocytosis. We have macrocytes, not only in megaloblastic anemia because of B12 folate deficiency, but also a number of conditions, including alcohol abuse and myelodysplastic syndrome, hypothyroidism. Another very interesting point he has mentioned is high MCSC, and that shows hereditary spherocytosis. And rule of 3 is very important. All of us must pay attention on RBC count, hematocrit, hemoglobin to find out whether rule of 3 is maintained or not. And one condition, he has presented that is cryoglobulinemia. There is a RBC agglutination. So these things are very important conditions, which as a physician, internist can diagnose looking at CBC. But this does not undermine the importance of examination of peripheral blood smear. So wherever there is any abnormal finding, we must request our hematopathologist to give us report by examining that, because you have seen that if size of RBC normal, if MCV is normal, that doesn't mean that patient does not have microcytic as well as combination of megalobulinemia. Another point is pre-analytical error. He has pointed out that 75% cases of errors, it is pre-analytical. How the sample was collected, where was it stored, and how it is transported. This is particularly relevant in case of thrombocytopenia, because platelets must be examined as soon as possible. The sample should not be kept at 4 degrees. It must be at room temperature. And also, preferably, if there is some doubt about platelets count, the sample must be collected in heparin or citrate vial rather than EDTA vial. So these are very important points and caveats Professor Kakkar has given to us. And I think that is very, very helpful for all of us while we do clinical practice. So that's all. And is Dr. Joseph John available or Dr. Bharadwaj?
Dr. Bharadwaj is available now.
Okay, so now
I'm sorry, it was not being unmute. Can you listen to me?
Yes, sir, we can.
Yeah. So, Professor, can you start your presentation, please?
Sure, thank you.
Okay,
good evening, everybody. My humble regards to all the senior members, past presidents, and the present president, Dr. Parikh, and all the Honorable Dr. Avasti, Dr. A.K. Tripathi, and everybody here. I'm sorry for delay in my unmuting. Let me start my this presentation. And I will speak on pancytopenia. Pancytopenia, it's a condition, you understand, where all the 3 types of blood cells are reduced. And when the especially platelets go less than 1.5 lakh and TLC less than 4,000, and hemoglobin becomes less than 11 in females and 13.5 in males. And the etiology of pancytopenia, it's bone marrow failure is the main cause, and maybe due to space occupying lesions, or there's ineffective marrow production. And second is the peripheral destruction of these hematopoietic cells. And then causes of pancytopenia can be inherited and or maybe acquired. Inherited, the causes are Fanconi anemia, dyskeratosis congenita. The very important causes are amegakaryocytic thrombocytopenia, hemophagocytic lymphohistiocytosis. And in the acquired causes, very important causes are infections like HIV, and hepatitis, and parvovirus, Ebola virus, and CMB. Then immune disorders like SLE, then PNH, and drugs. Very important causes. Next are the drugs, cytotoxic drugs, and anti-epileptic drugs, anti-thyroid drugs, which we are very commonly taking, and all thiazides, even NSAIDs, and some antibiotics like sulfonamides, chloramphenicol. Luckily, we are not using those in these days. And then pancytopenia, it can be associated with hypocellular bone marrow or cellular bone marrow. In the hypocellular, the pancytopenia, the causes can be acquired aplastic anemia, constitutional aplastic anemia like in Fanconi, some myelodysplasia, rare leukemic leukemia, and some acute lymphoid leukemia, and lymphomas of the bone marrow. Then similarly, the cellular causes or hypercellular and primary bone marrow disease like myelothysis, myelofibrosis, myelodysplasia, and same bone marrow lymphomas and hairy cell leukemia. Among the very commonly seen causes are acquired like secondary to systemic diseases like SLE, B12 folate deficiency, overwhelming infections like already said, tuberculosis and HIV, and leishmaniasis, even brucellosis, alcohol. These are some causes of hypercellular bone marrow, and very important in this is in the congenital aplastic anemia, which comes inherited. Then how to approach a case of pancytopenia? The history is very important, as in always clinically, the history taking, and then physical examination, then investigations. The important points in history are the age. In some cases, it gives the clue, inherited cause of bone marrow failure, like then duration of illness, history of bony pains, which gives the clue towards acute leukemias, fever in infections, night sweats in Hodgkin's disease, and malaise, generalized weakness indicates towards anemia, then weight loss, tuberculosis, malignancy, HIV, these are important causes. Then bleeding, that shows the magnitude of thrombocytopenia. Then important
the slides
points.
are not working.
Yeah, I will request Ajay to please. And
Ajay?
yeah, I had given to
Yes,
him.
please. Yes, sir.
Yeah,
Ajay, जरा सा
Please.
देखना slides का.
Sir, kindly, yeah.
Yeah, please.
Is it okay, sir?
Yeah,
full
and
slide.
carry on. Go, move ahead.
Full screen
Right,
नहीं हो
move
रहा,
ahead.
Ajay?
Move ahead. Yeah, move ahead. Yeah, another. Right. Here. Yeah, it's okay. Go back. And then jaundice. This gives a clue towards hepatitis, viral infection, the joint pains, malar rash, photosensitivity. Any history of radiation is important. Exposure to some potentially toxic chemicals, treatment history, including intake of herbals or drug intake, and blood dyscrasias, very important. Then physical examination. Physical examination with anthropometry is itself important, like in some congenital disorders like Fanconi anemia. And we will look for pallor, jaundice. We will find lymphadenopathy if it's there, that gives a clue towards leukemia, stomatitis, cheilitis. These things, they give a clue towards neutropenia or nutritional deficiency, very commonly seen in India. Then nail dystrophy, leukoplakia, and with skin pigmentation, we can think of dyskeratosis congenita. Then also we should look for oral hygiene. We will find out if oral candidiasis is there or some pharyngeal exudates, neutropenia. Then petechiae, purpura, we can say it's thrombocytopenia, sternal tenderness. We can get a clue towards acute leukemia, gum hypertrophy, acute myeloid leukemia. Then come lab investigations. It's very important. Dr. Naveen Kakkar has beautifully explained what CVC and CVC plays a role. We can straightway make the 50% diagnosis from CVC about pancytopenia. Peripheral blood smear, and then bone marrow aspiration and biopsy. Both are required and very important in congenital cases, especially when we suspect aplastic anemia. Then specific investigations for different systemic disease. Then for look in the CVC, I will cut short because already we have explained good and MCV, hemoglobin, and RDW. These are important things and help us to make a diagnosis. It has all been explained that the role of MCV, RDW, especially in IDA, and then dimorphic anemia, because if MCV is normal, RDW both are normal, and dimorphic anemia, slightly increase in RDW, and acute blood loss or hemolysis will be shown if it is between very normal range. Similarly, if this MCV is high, it is macrocytic anemia, and the two things are important. If RDW are more, then folate B12 deficiency. If they are fine, then aplastic anemia. So then peripheral blood film, look for anisocytosis and poikilocytosis. If it is both are there, RDW will be more. Then WBC and RBC precursors. Then platelets. Precursors we can find like Dr. Kakkar has explained, these all forms which are seen in leukemia of myeloid series, and then RBCs also, they can be there in anemia and polycythemia. Then platelets and granulation in neutrophils, these are also important. If there is granulation, marked granulation, we can easily say that there's a lot of infection or sepsis. And then neutrophils, hyposegmented and hypersegmented. And then slides, please. Further, can you move, Ajay? Then neutrophils, hyposegmented, like in myelodysplastic syndrome. Then hypersegmented, we can see. Then bone marrow examination. Check for cellularity in bone marrow. Hypocellular can be there with excessive amount of fat cells. The normocellular, and when fat cells and hematopoietic cells are almost equally there. Then hypercellular, then 80 to 100% cells with a little fat. And I want to show you. I'm sorry, Mr. Ajay, can you help? Yeah.
So the previous one or the next one?
Next one. Yeah, next one. Yeah, this one. Thank you. This is a hypocellular bone marrow. No. You have gone further. No. Go back. Yeah. Okay. So that we can make an idea that it's a hypocellular or normocellular, it's hypercellular, the different types. Next. Yeah. Next, please. Bone marrow examination. Both aspiration and biopsy are indicated. Bone marrow aspirate permits examination of cytology, immunophenotyping, and cytogenetics. Cytology is important for megaloblastic changes or dysplastic changes, and abnormal cell infiltrates, they are also important. Then immunophenotyping, the antigen or marker cells we can find on the and they can help us in leukemias and lymphoproliferative disorders. Cytogenetics is important if there's cytogenetics something different in chromosomal structure is there, then we can say it's myelodysplasia or leukemia or lymphoproliferative disorder. If it's all is good, then we can say it's simply aplastic anemia or simple lymphocytosis or simple infection. Then bone marrow finding cellularity, if it is hypercellular, it's megaloblastic anemia, hypersplenism. Dry tab we can see in myelofibrosis, then hypoplastic, myelodysplastic syndrome. Erythropoiesis, if it is dysplastic, then MDS, and increased, it is in hemolysis. Similarly, myelopoiesis, dysplastic changes are in myelodysplastic syndrome, and morphologically normal, these are other proliferating disorders. And if we have blast cells, we can say leukemias or even myelodysplastic syndromes. The megakaryocytic, megakaryopoiesis, again, if it is dysplastic, then myelodysplastic disorder. Next, please. Specific investigations we can have for hepatitis, we will order lefty. For megaloblastic anemia, we will order V12 and folic acid. Then serology, we will go for HIV, EV virus, hepatitis virus. Then ANA is seen in SLE. The bone X-rays will help in diagnosis of multiple myeloma and metastasis. And HAM test for PNH. Then chromosome breakage studies we do for Fanconi's anemia. Next, then management. First of all, any offending drug has to be stopped. Severe infections have to be treated with antibiotics. Severe anemia, we will have to transfuse blood. And if it is severe anemia, then we can give whole blood or leukocyte depleted blood with irradiated red cell that will prevent infections, transfusion reactions. Then platelet transfusion for severe thrombocytopenia, that we all clinicians know that up to 10,000 there may not be need, but that is the clinical decision that we transfuse at 10,000 or 20,000, or if there is any bleeding, we may have to give platelets even at 50,000. For surgery, it can be, we cannot do less than 1 lakh. Then broad spectrum antibiotics for severe infections. For severe neutropenia, we give granulocyte, CSF, colony stimulating form, or granulocyte macrophage, colony stimulating factors. Next, and red blood cell transfusion, packed red cells to alleviate symptoms of anemia, usually are indicated at hemoglobin values less than 7 or 8. It's the clinical decision. Then should be leukocyte depleted to lessen leukocyte and platelet sensitization and to reduce transfusion reactions, and radiated to reduce the potential for a transfusion related graft versus host reaction. Then transfusion, most patients tolerate counts up to 10,000 platelet transfusion, and without undue bruising or bleeding, unless a systemic infection is present or vascular integrity is impaired, then we have to give blood. And traumatic injury or surgery requires transfusion to greater than 50,000 and greater than 1 lakh microliter respectively. Administration of gamma amino caproic acid 50 milligram per kg per dose every 4 hours orally or intravenously may reduce the bleeding tendency. And prevention of infection, it's important with reverse barrier isolation, careful maintenance of skin hygiene, good dental care and rectal hygiene. Then scrupulous hand washing by medical and healthcare personnel routinely before examining any patient of pancytopenia is a simple modality for infection prophylaxis. And specific management is syngeneic or allogenic hematopoietic or stem cell transplantation. Combination immunosuppressive therapy with ATG and cyclosporin. And here I stop. Thank you very much. Thank you for patient listening, and sorry for interruptions in between.
Hello.
Invite next speaker. John has come. I can see him.
Yeah, sir. I am here. Yeah, I'm here only.
Thank you,
So
sir.
I think we don't. Yeah.
Yes, you can.
Thank you so
start.
much. Yeah. Thank you. Without much ado, I will go ahead with the discussions, and I think I have about 10-15 minutes.
Yes,
How
sir,
much?
you do
How many
have.
minutes?
10 to 15 should be fine, sir.
Sure. Okay. So I'll run through some of the slides, and I hope I want you to stop and ask questions if possible. And the bleeding and thrombosis is in a balanced state, which we have to keep the blood to zip about suspended there. And the platelet has a multifunctional attributes here, whether it is host defense or whether it is clotting or whether it is inflammation or tumor biology. But what we are concentrating in the platelet functions possibilities is what we are looking at. And if you look carefully, this is what the platelet looks like. I mean, if you look at the ADP, P2Y12 there, it's a clopidogrel which is acting there. And we have many other antiplatelets acting on various aspects of this in terms of phospholipid production. So platelet is not just a small amount, a small thing. I generally call this is like the kamikaze fighter planes. They will go there to the target area and sacrifice themselves by releasing these substances within them. And so basically, when we look at platelet disorders, we look at either a problem of number or a problem of function, which is the platelet dysfunction, which we call upon. This is our vexing problem in clinical practice, whether it is penias, whether it is a decreased production, or is it a peripheral destruction, or is it a sequestration? Sequestration is what we talk about, the platelets being deposited in the spleen and not able to come out. Peripheral destruction is the antibodies we're talking about. Decreased production is something infiltrating the marrow and suppressing the megakaryocytes, the mother of the platelets. So we can compare it on the hereditary and the acquired mode. In clinical practice, we often find the acquired one and not the hereditary. It is only usually the pediatricians may find some of the Bernard-Solé syndrome or Viscotaltic syndrome. But this is where we are mostly in is the immune, autoimmune phenomenon, the ITP or the infections or the SLEs. And sometimes it can be confusing with DIC and other problems. Of course, decreased problem like the previous speaker, Bardwaj, mentioned about the pancytopenia happening. Thrombocytopenia can be part of what Naveen said as anemia, or Dr. Bardwaj said about the pancytopenia. So we will zoom in on the ITPs there and see what else. Now, often we find these problems of morphological issues. One of the morphological issues so common is macrothrombocytopenia, or there is microthrombi, which we do not see normally, that is viscotaltic. Now comes a situation where classically you have a patient you got a consult patient is planned for a hip replacement or a cholecystectomy. Platelet count is 60,000, and you don't know whether to clear this patient or not to clear this patient in the absence of bleeding. We need to watch out for a few things. One is there a platelet satellitism? So you need to ask for a smear for sure, and the technician or the pathologist will be able to say that. And the other thing is what we look at any anisocytosis, which we see in myeloproliferative disorders. And this is an entity I want you to take home after this talk. One thing I want you to take home as a new entity is macrothrombocytopenia. This is a well-defined entity, not only in North India and East India and the South India as well, where the platelet size is large. And therefore, when you run the sample in a coulter, the platelet count will remain at 50 or 60,000. But when you do the smear, you will see large platelets there, and MPV generally it is more than 11. So take this piece home, and Naveen was here in Ludhiana when we published this paper. So macro thrombocytopenia is a known entity. They do not bleed and they do not have a problem. And what I want you to another take home from this talk is, do not stop patients from brushing their teeth. And we see this often saying that when the patient has dengue or the platelet is less than 20, do not brush your teeth, don't eat non-veg, don't comb your teeth, comb your hair. But these are myths in the process. In fact, you must tell the patient to use a soft brush the teeth twice a day to avoid gingivitis. So that is another key point I would want you to take home and say that even if there is gum bleed, please brush the teeth. It is not going to harm, it is only going to help. When we have a bleed, and this is a morphology, what happens microscopically, there is a vessel injury, explosion of collagen, there is an adhesion of platelets, and then followed by an aggregation of platelets, degranulation, secretion, and there is a flip-flop and the thrombin comes in. So this is the primary and the secondary hemostasis all bundled together. Let's say this is a case discussion. 30-year-old presents to you with a history of, I want some of the inputs. If somebody can unmute themselves and answer the question, how you would take it forward, that would be a good interactive session. 30-year-old lady presents with history of purpura of the legs and arms. That's the CBC report. What are the abnormalities you are finding here? Can anybody want to comment? What are the abnormalities here? In your clinical practice, what would you normally would have said? Okay, since nobody is responding, I would say that we are seeing an HP of 9 with an MCV is low. So there is iron deficiency state for sure. There is RDW. Yes, so hemoglobin is low. Okay, may I know who's speaking, please, sir? I don't see your name.
Dr. Arun Chabra.
Okay, sir. Thank you so much. So can you proceed with the rest of the problem? We have a high RDW. Naveen would have covered that. MCV is low and there is iron deficiency, right?
Yeah.
And HCT, PCT is 3 times 9 and there is thrombocytopenia.
Yeah.
What would you do normally in the clinical practice?
First of all, I would like to go for the peripheral smear.
Okay. Now peripheral smear is saying that, okay, retics is 3%.
Yeah, 3%, okay.
Peripheral smear says anisopoikilocytosis and no abnormal cells.
And what about the PS, peripheral smear?
That's what, sir. Neutrophils are 62%, lymphocytes 38%.
Any toxic, anything else? Any abnormality in the RBC? Nothing.
No abnormality in the RBC. They said anisopoikilocytosis.
So it is a purely iron deficiency anemia.
There is iron deficiency anemia, but look at the platelets, sir.
Yeah, platelet is low. What is the age of the patient? The age of the patient?
30-year-old lady.
30.
Such kind of things we see then when the platelets are low and the patients are bleeding, then simultaneously they develop the anemia and deficiency on top of ITP, maybe acute or chronic.
Absolutely.
Yeah, ITP.
You are absolutely right. So when you have a platelet count which is low and the patient has bleeding, then the next best thing is to do the marrow, because your differential diagnosis here is ITP. If the age was say 70 or something, you would have entertained a possibility of an MDS, but ITP will be high on cards here. Okay, so you do the marrow. Marrow is only going to show that it is a normal megakaryocytes. Okay, so my ITP is a diagnosis of exclusion rather than inclusion.
And this is more common we see in our female wards because of the chronic ITP. There are some few cycles of heavy bleeding and they'll end up with anemia, and then residents are labeling as cytopenia. But actually, it is ITP causing iron deficiency anemia.
Yes. Okay, moving from there, you have a classical case. Now they have an ITP, 42-year-old lady at 6 months history of ITP on prednisolone, while tapering the prednisolone to 25 mg, there is a drop in platelet to 25,000. What would be your next course of action? Continue lifelong prednisolone, high-dose pulsed steroid, plasma exchange, splenectomy, thymectomy, or even none of the above you want to answer? Not a problem.
We're going to add tenazole or azathioprine.
Okay, you're right. Okay.
Benazole for the supporting the thrombopoiesis can be tried.
Okay.
And if by increasing the dose of steroids patient is responding, then at a later date we can have steroid sparing therapy like azathioprine.
Good. I'm happy with that answer, sir. Now, since that is not the choice, splenectomy could be a reasonable choice. Okay. And so another take home is that try not to give more than 7.5 or 10 mg for longer periods. Sometimes we see patients who have been on steroids for more than 3 months, and generally we don't give more than 3 months. And as you rightly said, we need to give a steroid sparing drug in those settings. And let's say, yeah, this is exactly what you are talking about. If you cannot, low platelet is not a reason to stop brushing. Diagnosis of exclusion, first line is steroid, and the next line, as you said, dapsone, azathioprine, eltrombopag, and romiplostim, rituximab, splenectomy are the other options we have. And of course, IVIG is we keep it reserved for an acute emergency. We can go in for discussing ITP for the full session, but I will move on with another one. 20-year-old lady postpartum with normal vaginal delivery with seizures, unconsciousness, anemia, and thrombocytopenia. What are your differentials here, and how would you want to proceed?
ये मत रखना, ये पुराने रखो पुराने.
Slide is not properly visible.
Slide is not visible.
It's visible.
Yeah,
Not
visible,
properly,
very correct.
not properly visible.
Properly visible.
Sorry, hemoglobin, I can read it. Hemoglobin is 6, reticulocyte count is 8%, total count is 5,000, platelet count is 10,000, LDH is 1,500, and TV is
Total
6.
bilirubin is, yeah.
Direct bilirubin is 1, creatinine is 3. Total bilirubin is 6.
HELP syndrome? Could be something like HELP syndrome?
Yes,
Which
it seems
syndrome?
like to be.
HELP syndrome.
Have the transaminase values.
Okay, so you're close there. Not really HELP syndrome. Seizures, unconscious. So there is indirect. Sorry?
Okay.
Fatty liver of pregnancy? No, because OTPT is not elevated. No. There is indirect hyperbilirubinemia. There is renal failure. Sorry? Postpartum lady with seizures. So CNS is involved, kidney is involved, there is indirect hyperbilirubinemia, signs
DTP.
of intravascular.
DTP.
Yes, you are right. So peripheral blood now shows schistocytes. Okay. This is an important aspect to understand the schistocytes presence, and platelets are low, and this is sometimes missed because we think it is DIC. PT-APTT may be normal. That you're right about thrombotic, thrombocytopenic purpura. So this is one such patient who had a bleed and had all the pentads of TTP, which is uremia, renal failure, fever, neurological symptoms, seizures, thrombocytopenia, and hemolytic anemia. And the treatment there is aggressive transfusion plex, that is plasma exchange with FFPs. Though they are seeing two people who have been carrying FFPs in loads 10 and 20s, continues to give FFP in these patients. And it was heartening to see them coming out in the end. So generally the mortality is very high. It's important to continue this supportive care. Okay, there could be non-thrombocytopenic purpura. So all purpuras is not because of thrombocytopenia. Anybody wants to give a comment on this 5-year-old patient with skin lesions and arthralgia and colicky pain with palpable purpura?
It's a speak.
Anybody? Platelet counts are normal here.
Henoch is colon purpura.
Right. That is inoxaline purpura, and that is something we should not miss. And though it is mentioned in the children, it is seen in the adults as well. And we must be cognizant that it can happen. So some of these patients, and you biopsy them, you see the IgA type of purpura there. Okay, not related to thrombocytopenia per se. Anybody wants to give a diagnosis of an iron deficiency anemia, girl coming with a recurrent transfusion? This is what is seen on the mouth of the patient. And the brother happens to be visiting this patient, and the brother's face also has such lesions. What is the diagnosis? Iron deficiency anemia with perioral melanosis.
Sir, Peutz-Jeghers syndrome.
Wonderful. Thank you so much. Very good.
Yes, sir.
Okay. Patient comes to dental OPD.
Peutz-Jeghers syndrome.
Sorry? Sorry? What's your diagnosis? Platelet. So patient is come to dental.
Myeloid leukemia.
You are right. Gamma hypertrophy in acute myeloid leukemia. Which acute myeloid leukemia can cause this?
M3 variant.
No, not M3 variant. It is usually M4, M5 variants. Okay. This is a patient who had undergone aplastic anemia therapy with ATG. On day 21, she develops these lesions with joint pains and fever. What's your diagnosis? Sir, I think you're
serum sickness.
Sorry? You are right. Serum sickness is serum sickness is actually right. That is type 3 hypersensitivity reactions. So of course it is not because of it's more of a vasculitic lesion. Okay, what do you think the diagnosis is here? There are 4% blasts in the peripheral blood, thrombocytopenia with a mass in the face. AML, granulocytic sarcoma. This is, I'm looking at the platelet count and answering the question. Okay, so this is a 50-year-old man who presents with bluish discoloration of the body for last 10 years. Okay, and then you compress it, it goes back. His platelet count is 50,000. His PT is deranged. APTT is normal. What's your diagnosis? There's a vascular hemangiomas can cause localized DIC, and that's called Kasabet-Merritt syndrome sometimes. Okay, not very common, but if you have vasculitis, vascular malformations, that can be because of that. So that's your that features which were there. Okay, last two questions because time's up. 25-year-old man presenting with fever and URI symptoms for 1 week. Unremarkable, otherwise CBC revealed this. Mild hypertransaminasemia. What's your diagnosis? One thing you need to monitor, watch out here is that the HB is 10, but the PCV is 35, which means there is some hemo concentration. TLC is low with some lymphocytic predominance, and platelets are 70,000 with mild hypertransaminasemia.
Possibility of
dengue.
Absolutely right. So we are watching out for the platelets, you're watching out for the HB and the hemo concentration. Okay, last question because of the time limit. 50-year-old man with fatigue and no bleeding or fever referred with the following report. Platelets are 70,000, HB 70, 7, and MCV is on the largest side. Hematocrit is 22. What's your diagnosis?
Possibly megaloblastic anemia.
Megaloblastic anemia.
MDS. Very good. Because you picked up the macrocytosis. Retics are on the lower side, so it is a hypoproliferative anemia. TLC is low. You can have pancytopenia because of this.
Aplastic
The
anemia.
commonest cause of one of the commonest cause of thrombocytopenia referrals to mild OPD is cirrhosis and portal hypertension, especially pancytopenia.
Yes.
So keep that in mind. Common things first: macrothrombocytopenia, cirrhosis and portal hypertension, ITP. These other two are asymptomatic. Take home that all thrombocytopenia patients should brush their teeth and do not prevent them from doing that. Thank you so much, and I think I'll wind up today.
Question
There are more
17.
slides there. I think. Sorry.
Yeah, it's a very, very interesting presentation with case examples, Professor Joseph John. Congratulations. Yeah, just I would like to add one thing very important. Investigating for thrombocytopenia, lone thrombocytopenia, viral markers are negative. Even then, patient may be having chronic liver disease with thrombocytopenia. So for that, we always get ultrasonography and fibroscan. And in many patients, we get evidence of CLD as a cause of ITP. Otherwise, if we don't diagnose, erroneously we can give steroid and that can deteriorate the condition of patient. So one must
Thank you for bringing that.
CLD, even viral markers are negative, right?
Yes.
Sir,
Yes.
sir,
Point
just
well
one
taken.
question. Sir, one question. What is the positioning of dexamethasone 40 mg in cases of ITP, chronic, when they are on a lowest dose of steroid and sometime come up with the very low platelet count, then it is indicated in, it is written in the textbook. So many a time we are trying dexamethasone before IVIG or rituximab. So is it justifiable?
So the point is, the question number one you ask is the patient symptomatic? Okay. If the patient is symptomatic and not had a pulsed steroids in the recent past, then it is worth giving it. But if the patient has been on steroids for 5-6 months, I mean 2-3 months already, and the platelets are now 20 or 25,000 asymptomatic, no need to give. But if the patient is bleeding, yes, giving a short course of Dexa 40 into 4 days is reasonable.
Yes. Any more questions? Yes. Before we get any more question, can I ask Professor John, would you like to elaborate the importance of doing bone marrow test in ITP or thrombocytopenia? So,
So I think that's a good point you brought up. See, when in doubt and you want to start steroid, it's a good practice as far as possible, do the marrow before starting the steroids, because often if it is an acute leuk or any other lymphoid proliferative disorders, it can get masked. And if there is a reluctance from the patient side, or you are unable to do the marrow, then ensure that you do a good smear examination before proceeding. If you're giving IVIG, then you don't have to do the marrow. But general dictum is, though in the books it is not really, I mean, some of the Western literature says not really mandatory to the marrow. The Indian setting, we would still want to proceed with the marrow before the steroid treatment.
there is a question.
Dr. MP Singh.
Yes, sir.
Chat box question.
So there are two questions in the chat box. The first question is RDW, SD, CD. There are two values. Yes. Which one should be taken?
CV.
Yeah, there is a
CV
question.
or RDW.
There is a question on chat box. Role of mean platelets.
The second question is, the person wanted to know about IPV, immature platelet fraction.
Yeah, so you know what, that immature, it is not really on a routine basis. We are not looking at the immature platelet fraction to make any meaningful inference there, because that cannot rule in or rule out. There are some associations which have been brought in with ITP as the immature platelet fraction.
Any other questions from the audience are welcome.
Any role of finding out the platelet antibody in case of ITPs?
Yeah, so there is no role, sir. There is that is not a validated and substantiated test for diagnosing ITP. So diagnosis of ITP is essentially by the checking for the marrow being normal. The simple answer, no.
Yes, yes, sir. Yes, sir.
Okay. Okay, what exactly is leukocyte depleted irradiated RBC? So basically, you can reduce the WBC count. So generally, when you take the blood, there'll be about 1 into 10 to the power of 9 lymphocytes in the blood bag. The more the lymphocyte, the chances that these lymphocytes can attack the recipient WBC. So therefore, you do leukodepletion. Now, if you can do leukodepletion, the 10 to the power of 9 will become 10 to the power of 6. That's good enough. You do not want too much of donor WBCs going into the patient, especially lymphocytes. And that's the intent of doing a leukodepletion, because sometimes CMV carries in it HLA, anti-HLA. So HLA alloimmunization can happen because of this, or sometimes transfusion-associated GVHD can happen because of that. Irradiation is a one-stop methodology by numbing or knocking off all the lymphocytes there. So even if you do not have a leukodepleter, if you do leukodepletion, essentially the transfusion-associated GVHD can be reduced.
If there are no other questions or comment, I would now request Dr. Parekh sir to say a few words before we formally start the vote of thanks.
Excellent presentation by each speaker, and discussion was very good. Interaction should be very important, because this is the only thing which encourages to learn. And I think they have excellent presentation by all the three speakers. And I think we have become more wise, more updated regarding this very important hematological CME in our day-to-day practice, which we are coming every day, seeing almost every day so many CBC reports and so many things. So I think this must make more updated to our all delegates. And I would like to extend my sincere thanks to all the honorable guests, our learned speakers, and the chairpersons for sparing their valuable time. And special thanks to Dr. MP Singh for organizing such a nicely, wonderful, very important CME program on hematology. So next month we'll come out with something more very common topic, like any other which we'll discuss, but it should be of everybody's interest, to all the general practitioners and all our practitioners, clinicians. So good night and thank you very much, everyone. Dr. MPC, yes, conclude.
Thank you. On behalf of our president, Dr. Yes.
Namaste all. Congratulations, Dr. MPC. It was a very nice session.
Thank you, sir. On behalf of our president, Dr. Parekh sir, and all members of the governing body, I'd like to thank each and every one of you for sparing your valuable time and being with us till so late in the night.
Yes.
The commitment to the association of our president, the past presidents, Dr. Avasthi sir, Dr. A.K. Gupta sir, Dr. Madhu Chandakar, it was an honor and pleasure to have you with us Thank you for sparing your valuable time. It is always a pleasure to see Dr. Gursaran Sidhu, who has been an organizing secretary for conferences of CME and also a chairperson. Thank you, ma'am, for being here. Dr. Anil Kushresh also spared his valuable time and joined us from Gujarat. We'd like more active participation from him in further CMEs, and we'd like to see our association grow there too. Thank you, Pushpa sir, for being the co-moderator and helping me in every step. I would also like Dr. Professor A.K. Gupta to share his comments on the same before we say final goodbye.
Dr. NP Singh, virtual dinner के लिए offer कर दो, virtual dinner.
It was really very nice.
Offer the virtual dinner.
Yes, sir. We will.
Very nice. And my suggestion will be that in future, if we keep 2 lectures,
sure, sir,
elaborative, so half an hour, 2 lectures, and that will be better. It was a really very nice to listen all these speakers and being attended by all the members and all the dignitaries present and past.
Nice to see you, Dr. Gupta. Nice to see you. Great.
It was a special honor to have Professor Tripathi sir with us. He is the Dean of KGMU, and incidentally, I've done my neurology from KGMU, sir. It's a pleasure to see you, sir. I hope you become more active in our association and continue to bless us with your wisdom, sir. And all the speakers did their job tremendously well. They've hit the ball out of the park. It was a 6. And you'll be happy to know that this time also we scored a century. The number of participants at one time was more than 115. Thank you, sir. With that, I'll say good night and thank you for being with us.
Congratulations.
Good night.
Good night. Congratulations.
Congratulations.